Before I start on how we can extend life in good health, I want to think first of all about whether extending life in good health is going to be enough. Now, James Vopel used mortality as a surrogate for health this morning. I'm going to use disability. And I'm going to use as an illustration projections of life expectancy and disability-free life expectancy at age 65 from a simulation model that I've been developing as part of a project called MAP 2030, which models pensions and long-term care requirements of our ageing populations to 2030. And this slide shows projections of women's life expectancy and DFLE at age 65 over the next 20 years. And you can see clear increases in both life expectancy and disability-free life expectancy. So we're extending life in good health. But in fact, life expectancy will increase by just under 3 years, but disability-free life expectancy by only about half of that. So years with disability, DLE, will increase also and result in an expansion of disability. So I just want to point out that extending life in good health isn't enough. We have to extend it by more than the increases in life expectancy if we're going to reduce unhealthy years. So what exactly is good health in later life? Well, the main models of successful ageing, which were developed a couple of decades ago, include being free of disease and disability. Now, unlike wine, health and functioning tend not to improve with age. And that's not being just overly pessimistic, although there may be short-term increases in function and health. In general, over the longer term, health and functioning tend to not improve with age. How realistic is a model that says that you have to be free of disease and disability? How realistic is that for your 85-year-old, the fastest growing section of our population? As Tom Kirkwood said this morning, typically they had 4 or 5 diseases, and those were diagnosed diseases. They were not just self-reported. But they were still, many of them, living independently and living very socially active and engaged lives. So in many senses, we would say they were aging successfully, even though they were not free of disability. Now, too often, those models have been created by researchers with no input from older people themselves. So we need to include the views of older people. Now, as health and function is considered important, I want to briefly discuss some of the drivers of disability. And my framework for this will be the disablement process, as described by Verbrugge and Jetty, though most of the models of the disablement process are in fact very similar. And they all start with disease or pathology at the start of the process. Tom would say we start before that, and I agree, but most of the models start with disease. Moving through impairment and functional limitation, so that's things like visual impairment, hearing impairment, cognitive impairment at the body level, which then goes together to result in restrictions in daily activities. So essential personal care activities such as dressing and feeding, which feed into the need for long-term care, but also household activities, shopping, cooking, washing, etc. And then to fulfilling a role in society. Now, factors external to the individual all impact on that process, as do risk factors, predisposing factors, socio-demographic and lifestyle factors, and factors that are internal to the individual, changes in lifestyle like taking up exercise or our abilities to cope or adapt, the way we might accommodate changes in the way we do activities or functions like taking longer or not doing them as often. And I'll look at each of these, but in the next two slides, I want to focus first of all on the impact of diseases on disability and to consider how disabling particular diseases are. Now, this graph shows disability-adjusted life years in light blue, and Daniel Vasella earlier showed a graph with disability-adjusted life years in. And then in dark, for particular diseases, and in dark blue, it shows that the research spend on each of those disease categories. And this graph's from the UK Cooksey Review of Health Research Funding back in 2006. And what I want to highlight is that there are some conditions like respiratory disease, which has a big impact in terms of disability and mortality, so high disability adjusted life years, but a relatively small spend on research in that area. And compare that to stroke and cancer. Both of those have rather similar disability-adjusted life years, but you can see that the research spend on stroke is much, much less than the research spend on cancer. Now, thinking back to David's slide, it might well be that that picture differs between countries, and that might, in fact, be one of the reasons why we have different life expectancies and disability-free life expectancies. So it would be interesting to see how much that contributes to the differences that we see between countries. Now, that was for all ages. If we turn just to older age, this graph shows the disability, the population attributable risk of disability, so the disability attributed to different diseases for the population aged 65 and over. And population attributable risk takes into account not just the disabling effect of the disease, but the prevalence of the disease, which explains why musculoskeletal disease, like arthritis, has a very high attributable risk. 25% of the disability was attributed to arthritis because it has a very high prevalence. Over 50% of our 85-year-olds had some form of musculoskeletal disease. Eyesight problems, the next biggest population attributable risk. Both of those had relatively small research spends on the other slide. So maybe we need to be thinking about, what we're concentrating our money on if we want to resolve some of these issues about disabling disease. So let's look now at some of those factors that impact on the progression of disease to disability and participation. And for speed, I said that the external factors were things like technology, external support, environment, buildings, access. But I'm going to concentrate on medical care for speed. And although disease prevention's a worthy goal, we have to be able to manage the old who have multiple diseases and conditions. And a number of the speakers this morning have already spoke about this. And at least in the UK, this means general practitioners and hospital doctors have to rethink the way they work. And if you think about having on average 4 or 5 diagnosed diseases or conditions, some of those may be treated through the general practitioner, but some of them you will be referred to specialists, and that will probably entail multiple visits, separate visits to the hospital to see separate specialists. And in Newcastle, we're soon to be piloting some special clinics called Cresta clinics, where the older patient with multiple conditions will come and see all the specialists in one visit, and then the specialists can then get together, have a case study and discuss the best management. And that's in contrast to what happens at the moment, where your notes are passed backwards and forwards, information isn't passed on, and medical records get lost. So we're going to have to think a little bit more about that. And in these patients, postponing disability, postponing the onset of disability is going, or slowing progression, is going to be the target rather than the prevention of the disease that's already happened. So next, the predisposing factors and the intra-individual factors like making changes to our lifestyle. Now, there's good evidence that diet and exercise and social interaction can help us to age healthily. And we've certainly seen the diet from the splendid lunch that we've just had. However, we're not sure fully of some of the mechanisms of these. And we haven't been entirely sure, entirely successful at packaging them into in a way that the very old can take them up. So health promotion in the very old is something that we haven't really got very good evidence of at the moment. And we're also not at all sure whether some of these interventions are best taken up in midlife, whether they can be taken up in later life to the same effects. But there are also other things within us, how we cope with life events, having a positive attitude, and there's no doubt that socio-economic factors, education, wealth, social advantage, are not only main players, but they may also inhibit our ability to change our lifestyles or to employ strategies to compensate for failing function. And this leads on very nicely to something that Tom mentioned about inequalities. The fact that we could extend life in good health overall if we start to resolve some of the huge inequalities that are there between our countries. And this graph shows life expectancy, which is a full length of the bars, and healthy life years, the EU structural indicator, which is the dark blue bar, at age 65 within Europe. And they're ranked by female life expectancy, decreasing female life expectancy. And a couple of things to note. First of all, the relationship between the longest life and the most healthy life years isn't perfect. So the countries with the longest life expectancy at age 65 are not necessarily those that have the most healthy years. But what is very noticeable is at the bottom, the mostly Eastern European countries who have the shortest lives and the shortest years healthy. We see this evident across Europe, but we have gaps of this size within Newcastle, from one side of Newcastle to the other. So within countries, we find inequalities of this sort of size as well. So in conclusion, we need to be thinking about reducing unhealthy years as well as extending life in good health. So I know it has a more negative connotation, but just increasing healthy life years isn't enough. Most of the risk factors for diseases also play a part in accelerating the progression of disability. So concentrating on these is a start. But we need to more fully understand the mechanisms between diet, exercise, social integration, disability, and longevity, whether interventions are still beneficial in late old age, and how to design appropriate interventions. And we also need to address inequalities, and this may mean targeting specific hard-to-reach groups. And an emerging challenge with the growing numbers of the oldest old is to be more innovative at delivering healthcare to this age group with multiple diseases to ensure that they too maintain high levels of well-being and quality of life. Thank you.
Thank you, Professor Jagger. I have a question for you. You said that more attention and more funding is going to fatal diseases rather than disabling ones. Why so? Is it because we are more afraid of dying than being healed, or is it just, sorry for the provocation, because cancer is better PR?
Well, it could well be all of those. I think there are two issues. First of all, We've tended to focus on fatal diseases because that's the data we've had. Mortality data is much easier to get than disability, data on disability. So we've tended to focus on fatal diseases. So that's one reason why. But also, the slide that I showed was all ages. And I think we haven't had so much of a focus on disability in later life. And cancer is not the most disabling disease in later life by any stretch of the imagination.